The topic is valvular heart disease. The moderator is Dr. Jayanta Sharma, who is professor and senior consultant at Geriatric and Internal Medicine at Apollo Kolkata. And the speaker we have here is Dr. Sankha Subhra, senior consultant interventional cardiologist at Apollo Multi Speciality Hospital, Kolkata. So, sir, over to you.
Yeah, thank you, Sana, for this nice introduction. So, I am audible?
Yes, sir. Yes,
Yes,
sir.
sir, you are.
Yeah, fine. So, good evening, everyone. Good evening, all my colleagues. The Farz Academy, Dr. Asif Iqbal, and my today's distinguished speaker, Dr. Sankha Subhra. So, my dear friends, valvular heart disease is an important topic in clinical cardiology. For all the students as well as for the medical graduates, postgraduates, and the DRNB or DNB students who are practicing clinical cardiology, not only the cardiology student, for the medicine student and those who are practicing in the anesthesia as well as the critical care. In clinical cardiology, besides the interventional coronary artery disease and these things, the basic of cardiology depends on the valvular heart disease. Previously, 30 years back, the cardiology practice and everything was depends on the only the valvular heart disease because that was the bread and butter for everyone. Unless or until you know about the basics of valvular heart disease, you cannot proceed or progress in any subject in cardiology. And in clinical practice as well as in medical examination, in every exam, one long question usually comes from the valvular heart disease as well as in practical exam also either short case or long case will be on valvular heart disease because the murmurs, the heart sounds, these are very important in clinical practice as well as for the examination. By considering this all aspects, the Farz Academy as well as the chairman Dr. Asif Iqbal has been chosen this topic and none other than Dr. Sankha Subhra will speak on this subject because he is expert on this subject. As you know, the valvular heart disease is one of the major contributor of any cardiological issues in our country, specifically in India. The incidence of valvular heart disease at present in India is approximately 8.9%, and the global percentage or contribution of valvular heart disease from India is approximately 25 to 50%. And rheumatic heart disease is one of the most common cause. By considering this fact, so it is a very pertinent to read on this subject, to know about this subject, what is valvular heart disease, what are the common valvular heart disease, what how to diagnose it, and what is the latest technique and treatment of valvular heart disease. I am requesting Dr. Sankha Subhra, who is a very senior interventional cardiologist of Apollo Clinical Hospital, Calcutta, having more than 25 years of clinical experience and practicing cardiology. So, my sir, Dr. Sankha Subhra, this evening is for you. Just take over this and enlighten us about this valvular heart disease to our students and everyone so that we can learn something from you.
So, thank you very much, Dr. Sharma, for those wonderful words. And it was very true that when we were in our student days, I think valvular heart disease was the most hottest topic during exams, and acquiring skills in identifying a valvular heart disease, that what are the underlying valvular disorders the patient have. It is really a big clinical challenge for the MD medicine as well as the DM students. I think Dr. Asif, who is the chairman of Farz Academy, has rightly selected this topic for discussion today. So, good evening, everyone. Dr. Asif, Dr. Sharma, and all the students who are listening to this topic. Now, before I go forward, I will just ask everyone whether I am audible or not. Am I audible to
You
all
are
of you?
audible. You are audible. Absolutely, you are audible.
Fine. So, I will proceed to the subject proper. So, valvular heart disease, whatever I feel, is more of a neglected topic today, because the basic disease behind valvular heart disease is rheumatic heart disease. And with modernization, with improvement in healthcare, with awareness in healthcare, with awareness in personal care and hygiene, rheumatic heart disease has gone down in its prevalence. So it is mostly in the slum areas, in the lower socioeconomic areas, in few of the village areas where we still found valvular heart disease. In urban metro areas of Kolkata or in any other cities, it's very rare to find a patient of valvular heart disease. But it's true that the basic skills of an examining a patient of cardiology starts from examining rheumatic heart disease. No doubt about it. Still, at today's age, we still need to know a lot about valvular heart disease, how we approach this disease, and how do you come to a proper diagnosis. And it covers a lot of aspects of cardiology, because it takes the clinical cardiology, the history taking, it takes the examination part, there is a bit of ECG, there is a bit of echocardiogram, there is cardiac catheterization, and finally there is the management part, and also the newer managements that are coming in the spectrum of valvular heart disease. Now, frankly speaking, it is not possible to cover the entire topic of valvular heart disease in just one session. So I have asked Dr. Asif to divide this topic into two sessions, because I think after 1 or 1.5 hours, your brain does not receive enough of the knowledge, So better to divide this topic into two sets. So as Dr. Sharma was telling, that the basic disease behind
Excuse me, sir. Sorry to interrupt you, but I would request all the aspirants to mute your mic, and whatever question you have, please drop it in your chat box so we could answer after this session ends. Okay? Thank you.
So I will ask the listeners to mute their audio. Okay.
Yes, Sankha,
So, as we most of us know, that it begins with a group A streptococcal infection. That is a group A streptococcal pharyngitis. Now, why this group A streptococci specifically results in rheumatic fever, we really don't know. It is still something unknown. And why it is pharyngitis or some sort of skin infection that leads to rheumatic fever, but not a streptococcal infection in any other site of the body, that is also is unknown. So there are many issues which are still unknown. But whatever we know is this, that there is mostly a antecedent infection of group A streptococcal infection in the form of a pharyngitis or sore throat, which subsides. And normally after 4 to 6 weeks, the patient lands up with fever, arthritis, and cardiac manifestation that is called rheumatic fever. Now, many of the times this pharyngitis may be asymptomatic as well. We have seen that the patient does not have any antecedent history of a pharyngitis. Now, the most prevalent age of this rheumatic fever is normally between 4 to 15 years. That means the first or second decade of life. But it may be found as early as in the children of 3 to 5 years, specifically in highly endemic zones. Now, what happens is that basically it is an autoimmune phenomenon where there is an antigen sharing between the group A streptococcal bacterial antigen and a few antigens that are present in the myosin or in the valvular in the cartilage tissue of the joints. So what happens? There is formation of few autoantibodies that recognize certain tissues in the joints or certain tissues in the heart to be foreign antigen. So mostly this antibody is bound with the myosin in the heart or the valvular tissue in the heart, or it binds with specific structures of the synovial membrane of the joints. So they recognize such areas as foreign. So this is an autoimmune phenomena which is incited by a group of streptococcal infection and which we call as antigenic mimicry. And this is the basic mechanism how rheumatic fever begins. Now, as we all know that the major features of rheumatic fever are arthritis, carditis, Sydenham scoria, subcutaneous nodules, and erythema marginatum. So these are the major clinical presenting features of a patient of rheumatic fever. Now, arthritis is mostly affects in the young adult group. It is less common among the children or in early adolescence. It is mostly the young adults who normally have a severe affection of their joints. It is basically a large joint polyarthritis, which is migratory. That means once one joint has affected, subsequently the inflammation in one joint subsides, and next another joint gets affected. So it is a migratory polyarthritis. It may be additive as well. That means that one joint gets subsided and then one joint gets affected, or simultaneously 2-3 joints may also get affected. Now, normally the polyarthritis of rheumatic fever subsides by 3 to 4 weeks. If it continues beyond 4 weeks, then you have to think about some other connective tissue disorders in the form of systemic lupus or juvenile rheumatoid arthritis. And as I have told you that the arthritis of rheumatic fever is highly responsive to NSAIDs or aspirin. So if the arthritis is not responsive to aspirin or NSAIDs within a period of 48 to 72 hours, then you have to rethink your diagnosis that whether it is a rheumatic fever or something else. Now, rheumatic fever can also affect the single joint in the form of a monoarthritis. There is a sterile synovial inflammation with low complement levels. There is another form of arthropathy that is found in rheumatic fever. It is called Jacquard's arthropathy. Normally, any arthropathy of rheumatic fever does not result in any deformity. But Jacquard's arthropathy is a deforming arthropathy where there is ulnar deviation of the fingers, there is flexion of the metacarpophalangeal as well as hyperextension of the proximal interphalangeal joints. These deformities are mostly correctable, and these are all non-erosive arthropathies. So this is the difference between the arthritis of connective tissue disorders or rheumatoid arthritis. Please mute your.
Sana, you are doing hosting.
Yes, sir, I'm here.
You mute all this unnecessary voice, na?
Yes, sir.
Yes, the continue.
Yeah. So thank you very much. So rheumatic fever, even in Jacquard's arthropathy, this is one sort of arthropathy where you can have deforming arthropathy like rheumatoid arthritis. But the basic difference from rheumatoid arthritis is this, that rheumatoid arthritis is an erosive disorder. There is joint erosion. But rheumatic fever is always a non-erosive arthropathy. And the more thing is that there is the prompt response to aspirin, which is very much diagnostic of rheumatic arthropathy. There is another element called post-streptococcal reactive arthritis, which may also happen in children. But post-streptococcal reactive arthritis has a very short latent period compared to rheumatic fever, where the latent period between the streptococcal infection and the joint involvement is around 4 to 6 weeks. So as I told you, that carditis will affect from 40% to 90% of the patients. That depends upon the prevalence and the endemicity of that area. Now, in our time, it was only the clinical signs and symptoms that was recognized as definitive feature of carditis. But now the criteria has changed. There is an evolution of criteria of rheumatic fever, and eco-evidence of subclinical carditis is also now considered as a major diagnostic criteria according to the Jones criteria. So that is the marked change. In our time, if we can get a murmur, then only it is rheumatic fever. But now we can do echocardiogram. And if you get a subclinical evidence in the form of a small amount of MR or AR, that also comes as a major diagnostic feature. Now, as we know that the rheumatic carditis is pancarditis, it affects the valvular endocardium, the myocardium, and the pericardium. But the most specific feature of diagnosing rheumatic fever is involvement of the endocardium, that is valvulitis. This is the most definitive feature. A patient who have just involvement of the myocardium or pericardium, this is not rheumatic fever. It could be a viral myocarditis. Now, what happens that how these patients present with? So, this patient may just present with some chest pain of pericarditis, or they may frank go to valvulitis where the patient comes with features of heart failure. So, what happens? These patients develop a resting tachycardia. They may have a gallop rhythm. They may have a bibasilar crepitations. They may go to frank heart failure. They may have arrhythmias. And even these children may land up with sudden cardiac arrest. I remember in my student days when I was a house staff in pediatric cardiology, I landed up with a young male of rheumatic carditis who succumbed to sudden cardiac arrest. So you can just imagine the changeover. Nowadays, we rarely see a patient of rheumatic carditis with such a severity. Now, echocardiography helps in a lot in diagnosing rheumatic carditis, the early subclinical state. So a mitral regurgitation or a trivial aortic regurgitation, these are early features of rheumatic valvulitis. And almost in 18% of cases, it has been seen that the patient does not have any overt clinical features. A transient diastolic murmur of mitral stenosis due to rheumatic valvulitis is also sometimes present, which we used to know as a Caddy-Coombs murmur. But normally, remember that rheumatic valvulitis normally produce regurgitant murmur. So either it is an MR or it is an AR. Now, what happens to the mitral valve? There is annular dilatation. There may be caudal elongation. There may be caudal rupture. And there may be anterior mitral leaflet prolapse leading to mitral regurgitation. What happens to the aortic valve? Same thing. There may be leaflet prolapse. There may be leaflet thickening. There may be cooptation defect, or there may be restricted opening. And though echocardiography may be difficult for you at this stage, but still, this newer revised criteria has given some echo criteria for subclinical diagnosis of rheumatic fever. So, in a state of acute valvulitis, if you get an MR jet of length of more than 2 centimeters with a peak velocity more than 3 meters per second, or if you get an AR jet length more than 1 centimeter with a peak velocity more than 3 meters per second, these are considered a diagnostic feature of rheumatic fever, these criteria are all recently included in the revised Jones criteria of 2015. So echo is now considered was one of the essential criteria in diagnosing acute rheumatic carditis. Now next is Sydenham's chorea. Now Sydenham's chorea is basically a neurological event of streptococcal pharyngitis, and normally it happens much later in the disease course. There may be a long latent period of several months between streptococcal pharyngitis and the frank manifestation of chorea. It normally affects the females around puberty, and almost 40% of the children are affected by Sydenham's chorea. It has an insidious onset. Initially, the patient may behave with inappropriate laughing, crying, and the whole episode may last up to 2 years. Presence of Sydenham's chorea often coexists with associated carditis. Now, definition of chorea, we know from neurological knowledge that it is a semi-purposive or a quasi-purposive movement of the tongue, of the extremities mostly. There may be hypotonia and weakness of the upper limbs. Jack-in-the-box phenomena, is it? So it is protrusion of the tongue and taking it in, jack-in-the-box, or milking sign, gripping the fingers, or explosive speech, tongue fasciculation. But all these involuntary movements are normally absent during sleep. So these are the involuntary features of Sydenham's chorea, which is very diagnostic of in a young female. And treatment I will discuss later, but pseudomonas chorea is considered one of the major criteria, but normally it happens much later to the episode of rheumatic fever. The subcutaneous nodules is also present mostly in the extensor aspect of the body, over the back, over the extensor aspect of the knee, ankles, Achilles tendon. These are firm, mobile, painless nodules, and these are often associated with active carditis. Next comes erythema marginatum, which is a serpiginous, slightly raised, non-scarring, painless rash. Now remember that when you diagnose rheumatic fever, it is basically the arthritis and the carditis that normally we clinically meet in our chamber. The other three features, pseudomonas chorea, nodules, and erythema marginatum, these are all very, very rare features, and seldom do we meet these. It is just for academic interest that we need to know these aspects, because mostly we get either arthritis or carditis. Now, what is the supportive criteria in rheumatic fever? That is an antecedent history of group A streptococcal infection. Now, how do you diagnose an antecedent group A streptococcal infection? So either by a raised anti-streptolysin O titer, raised ASO titer, which was commonly done, still it is very much relevant, or raised anti-DNS B titer, a positive throat culture, or a positive rapid antigen detection test. These are also important diagnostic tests. But normally, the duration, the gap between an episode of rheumatic fever and the preceding streptococcal pharyngitis, the gap is almost 2 to 4 weeks. So by the time the patient lands up with rheumatic fever, most of the time the throat culture becomes negative, or the positive rapid antigen detection test also becomes negative. So that is the limitation or problem. So it is only this ASO titers or the anti-DNA B titers, these remains elevated for quite some time after a streptococcal infection. So measuring ASO titer is still very much relevant in diagnosing acute rheumatic fever. So what is this revised Jones criteria? So in our student days, when you used to study rheumatic fever, the criteria was 5 major criteria, and there are actually 4 or 5 minor criteria. The 5 major criteria were arthritis, carditis, pseudomonas chorea, erythema marginatum, and subcutaneous nodules. And the minor criteria was fever, arthralgia, prolonged PR interval, and raised acute phase reactants like CRP or ESR. Now, these revised Jones criteria, they have shown that the initial rheumatic fever, either you have 2 major criteria that is sufficient to diagnose, or 1 major plus 2 minor criteria. If it is a recurrence of acute rheumatic fever, then 2 major criteria is sufficient to diagnose it, the recurrence, or 1 major is 2 minor, or 3 minor criteria is sufficient to diagnose a recurrence of rheumatic fever. In the revised Jones criteria, some changes in the manifestations has been included, like some manifestations may be found in the low risk population and some manifestations in the high risk population. Like for the low risk population, if it is a polyarthritis, then only it comes under a major criteria, not arthralgia. But in a high risk population, even a polyarthralgia or a monoarthritis comes under major criteria. Concerning minor criteria, in a low risk group, it may be polyarthralgia, it may be a fever more than 38.5, ESR more than 60, a CRP high compared to the normal range, and a prolonged PR. And if you think about the minor criteria in the high risk group, then a monoarthralgia, fever more than 38 or ESR more than 30 should be considered. So there has been some changes in the major and minor criteria according to the prevalence of the area where we are diagnosing rheumatic fever. Now, treatment. So treatment, obviously, you have to treat the underlying group A streptococcal pharyngitis. That is the most important. That is the primary treatment. And then comes the secondary prevention. So eradication of group A streptococci, the best way of doing it is a single intramuscular dose of benzathine penicillin, or you can go for oral penicillin, or if the patient is allergic to penicillin, you can give macrolides also. For the rheumatic arthritis, as I told you, it is aspirin, aspirin, and aspirin. The patient should have a dramatic response to aspirin if it is a rheumatic polyarthritis. There are some other NSAIDs also like naproxen. It is a very good alternative to aspirin. If it is not responsive to aspirin or naproxen, you can try with steroids. But as I told you, that if an arthritis continues beyond 4 weeks, you have to think that it could be something else like SLE or a juvenile rheumatoid arthritis. Next comes carditis and heart failure. So even a child of heart failure will you will treat the same way as an adult with heart failure. So obviously we'll give diuretics, fluid restrictions, beta blockers, ACE inhibitors, ARBs, mineralocorticoid receptor antagonists. It is just the same, all the medicines for heart failure. Now the issue is that if it is a severe valvulitis with severe amount of mitral or aortic regurgitation, then sometimes it may not respond with conventional therapy. As I told you, that in my student days, I saw a patient that we lost that patient with rheumatic carditis. So you have to try steroids in those subsets of patients who land up with intractable heart failure. And even in some subsets, even an emergency surgery can be helpful. But it's very important to balance that whether the rheumatic activity is active or not. Now, for a rheumatic chorea, oral penicillin, either same way, it is either oral or a benzathine penicillin G is good for treatment. For the neurological complications, you can give haloperidol, carbamazepine, and in refractory cases, you can try valproate. Concerning therapy, as I told you, dramatic response to aspirin or naproxen. And for the refractory cases of heart failure or the refractory cases of arthritis or a refractory rheumatic fever, you can try with oral steroids or IV steroids or methylprednisolone bolus dose. And you can't continue steroids for a very long time. Normally, we give steroids in rheumatic fever for a period of 2 to 4 weeks. And then we gradually taper steroids and we replace steroid again with oral aspirin. Secondary prophylaxis, I have discussed about the primary prevention. For secondary prophylaxis, well, we have categorized patients of rheumatic fever in 3 ways. So those patients who have an episode of rheumatic fever but without any echo evidence of carditis. Those patients who have mild echo evidence of carditis in the form of a trivial mitral regurgitation, trivial aortic regurgitation, but it is a healed carditis. And those patients who have a frank rheumatic heart disease, maybe a hemodynamically significant valvular disorder. So these are the 3 subsets of patients. So for children who have no echo evidence of carditis, you have to continue the secondary prophylaxis, which is basically either benzathine penicillin G injection or oral penicillin, either up to the 5 years from that episode or up to the age of 21 years, whichever is longer. For those having mild carditis in the form of a rheumatic mitral or aortic regurgitation, but healed valvulitis, you have to continue the prophylaxis for 10 years after the last episode or up to the age of 25 years, whichever is longer. And those patients who have a hemodynamically significant rheumatic heart disease, be it an MS, MR, ASAR, well, either you can continue this secondary prophylaxis lifelong or up to the age of 40 years. The best possible prophylaxis is obviously benzathine penicillin G. As we know that if the body weight is less than 27 kg, it is 0.6 million units. If it is more than 27 kg, it is 1.2 million units. Deep intramuscular injection every 2 weeks or every 3 weeks. In those areas where rheumatic fever is very much endemic, ideally it should be every 2 weeks. In those areas with lower prevalence, it can be every 3 weeks. It's a very, very painful injection, and often you have to give some sort of pre-medications or you have to give some sort of anti-allergic medications before giving benzathine penicillin. And the issue of benzathine penicillin is availability. It is rarely available now. So the other options is oral penicillin V. So next, I will discuss a bit of valvular disorders today. I can't discuss all the valvular disorders. Now, as we know that rheumatic heart disease most commonly affects the left-sided valves, that is the aortic valve and the mitral valve. Seldom it affects the tricuspid valve as well. The mitral valve involvement is mostly in the form of a stenosing deformity like mitral stenosis, regurgitant deformity, mitral regurgitation, or a mixed deformity where there is both MS and MR. Aortic involvement is mostly in the form of a stenosing variety, that is aortic stenosis, a regurgitant variety, aortic regurgitation, or a mixed variety like AS with AR. If you think about the affection of the mitral and aortic valve, then the commonest affection is the mitral valve, and the next commonest affection is the aortic valve. So almost it has been seen that almost 60 to 70% of the patients of rheumatic heart disease mostly have a mitral valve involvement in the form of a mixed mitral valve disease. Isolated aortic valve involvement is normally found around 20%. Majority has an overlap of mitral and aortic valve as well. Now today, for the sake of discussion, to make it easy, I will just discuss the aortic valve disorders, aortic stenosis and aortic regurgitation. Next day, we will discuss mitral valve disorders in the form of MS and MR. Now, suppose you are given a patient of aortic stenosis in the exam. You know, aortic stenosis is progressively rising. The cause is basically with increasing longevity, degenerative aortic valve disease is now very, very common. And it is now very common to get an aortic valve disorder in the exam comparing mitral valve disorder, because degenerative aortic valve disease can often come as an exam case now, both in undergraduates and postgraduates. Mitral valve disorder is comparatively rare now. Now, what are the causes of aortic stenosis? Either it is degenerative, as I told you, age-related, which happens normally after the age of 60s or 70s. It could be a congenital aortic valve disorder in the form of a bicuspid aortic valve, which is the most commonest congenital heart disease in adults. And last but not the least, in our country, it is rheumatic. Now, as I told you that normally aortic valve is a tricuspid valve. Now, what happens in bicuspid aortic valve? So there is basically a fusion of the leaflets. So one leaflet gets fused with the other leaflets. Normally, it is the right and the left coronary leaflets that normally commonly fuse with each other. Sometimes it is the right and the non-coronary leaflets that normally fuse with each other to produce an raphe, and ultimately it comes to be a bicuspid aortic valve. So the job or the hemodynamic load that was to be distributed by 3 cusps is getting done by 2 cusps. The 2 cusps are doing the job of 3 cusps. So obviously, the hemodynamic stress, the hemodynamic pressure has to be much, much more. So this effect of shear stress and strain, what happens? There is progressive degeneration of these bicuspid aortic valves in the long run, and they either land up with a stenosing deformity or a regurgitant deformity. Mostly bicuspid aortic valves, they land up with a stenosing deformity around the age of 50s or 60s. Very few of them land up with a regurgitant deformity as well. So what are the various types of cuspal deformities in aortic valve? It could be unicuspid, it could be bicuspid, or it could be quadricuspid. Out of them, unicuspid valve mostly found among the neonates and among the pediatric age group. It produces severe aortic stenosis. The severest aortic stenosis is produced by unicuspid valves. These patients normally rarely survive unless you do some sort of intervention. Now, bicuspid aortic valve prevalence is 1 to 2% in adult population. It has a male preponderance in the ratio of 3:1 male-female ratio. And it has been often seen that bicuspid aortic valve disorder is often transmitted genetically, with a 9% prevalence of bicuspid aortic valve among the first-degree relatives. Now, bicuspid aortic valve can be just isolated in about 50% of the cases. And in other 50%, it is associated with some sort of congenital disorders like the Turner syndrome or the coarctation of aorta. And remember that the aorta in bicuspid aortic valve has some sort of collagen defect, which is called aortopathy. And the aorta in bicuspid aortic valve, they often land up with aortic dissection or aortic aneurysm. As I told you, that the commonest variety of bicuspid aortic valve is a congenital fusion of the right and the left coronary cusp. Sometimes it is also a fusion of the right and the non-coronary cusp as well. As I told you, that aortopathy, that is in the form of aortic dissection or aortic aneurysm, it is 5 to 9 times more common in patients of bicuspid aortic valve. So it's a very, very high prevalence. Now, what are the risk factors for a patient to develop aortic stenosis? You know, genotype is very strong. Several genotypic mutants has been found, like especially lipoprotein little a, vitamin D receptor, fibroblast growth factor receptor. Several mutations has been linked now with aortic stenosis. And those patients who have a lipoprotein little a receptor mutation or a fibroblast growth factor receptor mutation or a vitamin D receptor mutation, they have increased prevalence of calcification as well as degeneration of the aortic valves. These aortic valve leaflets have 3 layers. One layer is towards the ventricle, that is the ventricularis. One layer is towards the aorta, that is the fibrosa. And one layer is in between, that is the spongiosa. This is the spongiosa layer as well as the fibrosa layer where the degeneration begins. Second risk factor is at-risk morphology. As I told you, that quadricuspid or bicuspid are very prone to develop aortic stenosis. Male patients, elderly patients due to sclerodegenerative conditions, dyslipidemia like familial hypercholesterolemia, diabetes mellitus, metabolic syndrome, smoking, hypertension, chronic kidney disorders, high serum phosphate, all these are risk factors for development of aortic stenosis. So as I told you, what happens that when 2 cusp is doing the function of 3 cusp, there is increased shear stress over the leaflets. These leads to inflammation, there is lipid infiltration, there is inflammatory cell infiltration, there is release of growth factors, there is myofibroblast differentiation, there is hydroxyapatite nodules, and ultimately there is cartilage and bone formation, so calcification. So this is the basic pathophysiology how aortic stenosis, specifically the degenerative aortic stenosis, develops. Now, what are the commonest symptoms in aortic stenosis? So the commonest symptom is angina, syncope, and dyspnea. So the dyspnea is the terminal symptom, and if aortic stenosis patient develops dyspnea, you know, the prognosis is quite bad. Angina is quite common in the beginning part of the disease. Why angina happens? Because in aortic stenosis, there is a fixed obstruction to the LV outflow. So there is significant LV hypertrophy. What happens that the coronary perfusion happens during diastole. So since there is a significant LV hypertrophy, the diastolic perfusion of the coronary arteries gets impeded due to inadequate relaxation during diastole. Secondly, there is inadequate capillary density as well compared to the hypertrophic myocardium. Thirdly, there is an elevated LV and diastolic pressure. And fourthly, there may be an associated coronary artery disease as well. So all these features together impairs the coronary perfusion, which leads to angina. As I told you, that symptoms normally develops at the age of 50 to 70 years in case of bicuspid aortic valve, or after 70 years in case of degenerative aortic stenosis. The symptoms in one way, since there is LV hypertrophy, there is elevation of LV and diastolic pressure. And this elevated end diastolic pressure transmits backwards towards the left atrium, and this left atrium pressure transmits backwards to the pulmonary veins. So this is one way how this patient lands up with dyspnea and orthopnea. Besides, fatigue is also a significant feature because the cardiac output does not appropriately increase to the metabolic demand. Angina, as I told you, it is due to the disproportionate left ventricular hypertrophy where the capillary density is low compared to the hypertrophied myocardium. There may be endothelial cell loss inside the capillaries. There may be diastolic compression of the capillaries, and there may be as well epicardial stenosis. All this together leads to angina in a patient of aortic stenosis. Syncope. There is a fixed obstruction to the LV outflow in aortic stenosis, and the syncope can happen in rest or the syncope can happen during exercise. Now, what is the cause of syncope during exercise? During exercise, there is an inappropriate vasodilatation. So the cerebral perfusion is compromised. Besides, there is a baroreceptor dysfunction and also there is a vasodepressor response to elevated LV systolic pressure. So all this leads to a low cerebral perfusion leading to syncope. Besides, in severe aortic stenosis, patients are also prone to arrhythmias. They can have bradyarrhythmias or tachyarrhythmias. As we know that severe aortic stenosis patients are very prone to sudden cardiac death due to intractable VT. Remember that if an aortic stenosis patient goes to VT, the chances of survival is very, very low. Even if you cardiovert the patient electrically, it's very difficult to get a normal rhythm. So be very careful about a severe aortic stenosis patient landing up with VT. I have very bad experience. Besides, in aortic stenosis, what happens that the aortic valve calcification, it extends to the AV node. So these patients often have first degree AV block, and even they can have second degree or third degree AV block. Besides, atrial fibrillation is very important. Now, how an aortic stenosis patient develops atrial fibrillation? Now, as we know that in aortic stenosis, there is significant LV hypertrophy. So the LV cavity is small. So during early diastole, there is very little feeling of the LV cavity. And much of the diastolic feeling depends upon atrial contraction. Now, if due to some reason, due to enlargement of the left atrium, if the atrium rhythm is lost, if the patient goes to AF, then this terminal part of atrial feeling is compromised and the patient goes to a low output state. And this is one of the cause of syncope in aortic stenosis patient. So atrial fibrillation in a patient of aortic stenosis is very, very ominous and it can lead to syncope as well. GI bleed. As we know, I think we have heard about this name, heat syndrome, where there is angiodysplasia. What happens, that the platelets are moving through the stenotic aortic valve and they are exposed to increased shear stress. And the shear stress induced platelet aggregation with reduction of the high molecular weight von Willebrand factors leads to formation of vascular malformations, mostly in the right ascending colon. So there is angiodysplasia in the ascending colon and it lands up with GI bleed. And this is called heat syndrome. I have met one patient, who had an aortic valve prosthesis, a metallic aortic valve, and he landed up with GI bleed. And lastly, the diagnosis came to be angiodysplasia. Besides, some other complications of severe aortic stenosis is infective endocarditis of the aortic valve, which can subsequently embolize, which leads to embolic stroke. Now, what are the clinical findings? When you get a patient of aortic stenosis, how do you examine the patient? So whenever you approach a patient, you just give a look at the patient that whether the patient is at peace or whether the patient is in shortness of breath. So if the patient is having a shortness of breath, then probably the patient is in failure. Now, normally during exams, you get a calm and quiet patient. So in peripheral survey, or you look at the patient, what do you see? Is there any specific phases in aortic stenosis? Well, if the aortic stenosis is specifically secondary to Turner syndrome or supravalvular aortic stenosis, you may get some specific phases when you look at the face of the patient. Normally in rheumatic aortic stenosis, you don't get any obvious facial abnormalities. You look at the chest for any specific scar mark or deformities. You approach the patient and check the pulse. How is the pulse? In severe aortic stenosis, you get a low volume pulse, which we call pulsus parvus et tardus. Now remember that there are two notches in the vascular pulse. One is the notch in the ascending limb, one is the notch in the descending limb. And the ascending limb notch is called the anacrotic notch, and the descending limb notch is called the dicrotic notch. So this pulse is also called anacrotic pulse, as this anacrotic notch gets prominent. So pulsus parvus et tardus means low volume delayed peaking pulse. You can also make this similar quality in the carotids, where there is a slow rising late peaking pulse of low amplitude. You can also make out a palpable thrill over the carotids. That is called carotid shudder. Now, sometimes aortic stenosis may coexist with aortic regurgitation, and you can make out a double peaking pulse in the carotid, that is called pulsus bispherians. Sometimes the right subclavian pulsations or the right brachial pulsations are more prominent compared to the left subclavian or left brachial pulsations. This is found in specifically congenital supravalvular aortic stenosis, where there is specific streaming of blood towards the right side of the great vessels. Now, it is not necessary that in a patient of severe aortic stenosis, the carotid impulse will be of low volume. It may be normal volume also if the aortic stenosis coexists with hypertension or aortic regurgitation. Now, how is the apex beat in aortic stenosis? Now, in aortic stenosis, you get a concentric hypertrophy of the LV. So the LV hypertrophies inside instead of outside. So the apex beat is a forceful, well-sustained apex, and it is almost in the same place, that is the left fifth intercostal space, without much displacement down and out. So that is the apex beat, forceful, well-sustained apex. And those who are very good in clinical examination, you can make out a palpable fourth heart sound, palpable S4. It is not necessary that you have to make it out, but you have to know the character of the apex. That should be forceful, well-sustained apex. It should occupy more than 2/3 of the diastole, and normally it is not displaced down and out. Next, what are the other palpatory features? You can palpate the base of the heart, that is the pulmonary area, then the aortic area, and the neo-aortic area. Now, in the pulmonary area, if the patient is in pulmonary hypertension, you can make out a palpable P2. In the aortic area, you can make out a thrill if the patient has a severe aortic stenosis, a palpable thrill in the aortic area. Now, what happens to the S1, first heart sound, in patients of aortic stenosis? S1 is normal as such. If the LV EDP is significantly elevated, sometimes the S1 is soft. What happens to the second heart sound? S2. Now, S2 has two components, A2 and P2. Now, obviously, if it is a valvular aortic stenosis, then specifically rheumatic aortic stenosis, the A2 will be soft. But if it is a bicuspid aortic valve, then often the intensity of the A2 remains preserved. Now, many of the times you can get a single S2 in a patient of severe aortic stenosis. What may be the reason for single S2? That means it may be either the A2 is absent, very soft A2, or since there is a long ejection systolic murmur, the second heart sound gets submerged in the ejection systolic murmur, or sometimes since the systole is delayed, the A2 and the P2 may coincide together. So these are the so many reasons of a single second heart sound. Next, what are the added sounds in aortic stenosis? Do you get any added sound? Normally, in sclerodegenerative aortic stenosis or in rheumatic aortic stenosis, you will not get any added sound. But if it is in bicuspid aortic valve, you will get an ejection click. How the ejection click is produced? It is due to the abrupt halting of the opening of the movement of the stiff aortic valve that produces the ejection click. So the ejection click normally happens immediately after the second heart sound. So that is called the ejection click. So next comes what are the murmur? Ejection click often best heard in the apex, and it normally happens after it should be happen after the first heart sound, not the second heart sound. So in S1 ejection click interval, it basically signifies the severity of the aortic stenosis. So shorter is the S1 ejection click gap, severe is the aortic stenosis. So sorry, so ejection click is a systolic sound and it happens after S1. It is a high pitched sound and it is well audible over the LV apex. Next comes the murmur. So in severe aortic stenosis, you get an ejection systolic murmur, which is a diamond-shaped murmur, and which is normally peaks during mid-systole. It is a rasping quality of murmur, which is best audible either in the new aortic area or in the aortic area. And it is normally audible over the sash area. What is sash? So it is a piece of the cloth when we keep it over the shoulder, that is called the sash area. So this murmur is best audible over the sash area, and longer is the ejection systolic murmur, and later is the peaking in the murmur. Severe is the aortic stenosis. And sometimes due to severe vibration, a few component of this murmur gets transmitted to the apex, and you get a very well audible murmur over the LV apex as well, which is called Gallaverdin phenomena. So Gallaverdin phenomena is basically selective radiation of vibrations from the aortic root up towards the apex. So that is called Gallaverdin phenomena, and that's why this murmur of aortic stenosis is also very well audible over the LV apex. This murmur often gets augmented by squatting, and it gets reduced by Valsalva's or standing maneuver. If you get an LVS3 in a patient of aortic stenosis, then the patient is obviously in heart failure. LVS4 may be physiological because of very stiff left ventricle. So I think this finishes the clinical examination in a patient of aortic stenosis. ECG. Now ECG shows significant LVH with strain pattern T inversion in the lateral leads. There may be left atrial enlargement, so you can get a biphasic P wave in V1. There may be a left axis deviation. Due to conduction disturbances, you may get a first degree AV block, or you may get second degree AV block. If there is LV dysfunction, you may get VPCs, or you may even get non-sustained VTs. Now, if it is sometimes a congenital valvular aortic stenosis, you may get a post-stenotic dilatation in the aorta. And normally, where do you make out this aortic valve calcification? If you draw a straight line from the right cardiophrenic angle up to the pulmonary bay, this aortic calcification is just above this line. So a straight line from the right cardiophrenic angle to the pulmonary bay, the aortic calcification remains just above that line. So ECG and chest X-ray. Now, what is the normal aortic valve area? It is 3 to 4 centimeters square. What is mild aortic stenosis? Less than 2 centimeters square. What is moderate aortic stenosis? Less than 1.5 centimeters square. What is severe aortic stenosis? Less than 1 centimeter square. So this is the classification of severity of aortic stenosis according to the area. Can you please mute the video audios? So let me discuss a bit of echocardiogram when you discuss about aortic stenosis. Now, I know that since you are all maybe doing your MDs or even in medicines or in DNBs, so you may not be well adversant with echocardiogram. So I will not go into the details of echocardiogram in today's class. I will just say you the salient features what we get in echocardiogram. Now, echo has a parasternal long axis view, and it has a parasternal short axis view, and it has an apical four-chambered view. Now, this is basically an apical short axis view, parasternal short axis view, where you can make out these 3 leaflets. And this is, you can make it 2 leaflets. So this is basically a bicuspid aortic valve, which later degenerates into aortic stenosis. This is a parasternal short axis view. Now, ECG, chest X-ray and ECG we have discussed. Now, this is basically a parasternal, this is basically, apical 5-chambered view, where this is the left ventricle, this is right ventricle, this is left atrium, this is right atrium, and this is the aorta. And this is aortic calcification. So what we do is that we take a continuous wave Doppler tracing along this aortic valve to see the gradient across the aortic valve. Now, if the mean gradient across the aortic valve is more than 40 millimeter of mercury, or if the velocity across the aortic valve is more than 4 meters per second, we consider it as severe aortic stenosis. This is a simple way of diagnosing aortic stenosis. You do a continuous wave Doppler across the aortic valve. If the velocity is more than 4 meters per second, or if the mean gradient is more than 40 millimeter of mercury, we call it severe aortic stenosis. Anything less than that may be a mild or moderate aortic stenosis. So this is an easy way. At risk of aortic stenosis, where the velocity is less than 2 meters per second, progressive aortic stenosis, that means mild or moderate aortic stenosis, where the gradient is either less than 20 or 20 to 40 millimeter of mercury. So these are all the stages where you don't intervene. Next comes asymptomatic severe aortic stenosis, where the velocity is more than 4 meters per second or the mean gradient is more than 40 millimeter of mercury. Now, asymptomatic severe stenosis either can have a good LV systolic function or it can have an LV ejection fraction less than 50%. Next comes symptomatic severe aortic stenosis, where there is high gradient as well as high velocity. Now, symptomatic severe aortic stenosis can have a low flow, low gradient aortic stenosis. You know, there are many patients of aortic stenosis who land up with LV dysfunction. Say the ejection fraction is 40%. And since they have an LV dysfunction, the gradient also declines. So how do you ascertain that whether it is a severe aortic stenosis or a moderate aortic stenosis in a patient of AS with LV dysfunction? So you subject these patients to dobutamine stress echo. So if you do a dobutamine stress echo and if the gradient increases to more than 40 or the velocity becomes more than 4 meters per second, then it confirms that this is severe aortic stenosis. Another element of aortic stenosis is a pseudo aortic stenosis, where there is severe aortic stenosis by area, but the gradient is low. Now, these are some subsets of patients like, hypertrophic LV, hypertensive heart disease, or hypertrophic cardiomyopathy, where the diastolic feeling is low. So it is a low flow state, and so the gradient is also low. So this is also another element where you have to see the stroke volume index. And if the stroke volume index is low, then this is also another subset of pseudo-severe aortic stenosis. So lastly, discussing about management. Now, any patient of severe aortic stenosis, it is not that medical therapy is not an option. Yes, if he is hypertensive, he will give antihypertensives. If the patient is in failure, he will give diuretics. He will give anti-ischemic therapy. If the patient has an ischemic heart disease, you will give statins. If the patient has AF, you will give anticoagulation. And lastly, if the patient has a criteria for going for surgery, then you should think about surgery, either a surgical AVR or a transcatheter AVR, that is TAVI, which is now a hot topic today. Now, how do you approach a patient of aortic stenosis regarding what type of therapy you will go? Now, any patient who is a patient of symptomatic severe aortic stenosis, he ideally qualifies for surgery, either a surgical AVR or a transcatheter AVR. Now, if a patient of symptomatic severe aortic stenosis is less than 50s or 55, obviously he is a patient candidate for surgical AVR. And if he is more than 65 or 70, you have to balance whether you will go or surgery or a TAVR. If the patient is not fit for vitamin K anticoagulation, then ideally the patient is fit for a prosthetic aortic valve. And then you have to again see the age of the patient. If the patient is comparatively young, you can go for a bioprosthetic valve. If the patient is elderly, you can go for a TAVI. So there are many aspects in it. So what are the indications of definitive intervention? One is symptomatic severe aortic stenosis. You go for SAVR or TAVR. Asymptomatic severe aortic stenosis. If the patient is going for CABG, you can go for a surgery, TAVR or SAVR. If the Vmax is more than 5 meters per second, if the patient has symptoms during stress test, if the BNP or N-terminal NT-proBNP is more than 3 times high, if there is a progressive decrease in LV ejection fraction. So all these are indications for surgery in an asymptomatic patient of severe aortic stenosis. Now, what are the options? You can go for a surgical AVR if the patient is less than 65. You can go for a TAVR if the patient is more than 80 years. And if the patient is in between, then there is a heart team approach where the cardiologist, the cardiothoracic surgeon, and the medical specialist all sit together. They will consider all the comorbidities of the patient. They will discuss with the relatives, and they will discuss about the merits and demerits of surgical and transcatheter AVR, and then take a decision. Now, in a symptomatic patient of severe aortic stenosis, if the risk score is very high, if the patient is very frail, if the patient has multi-organ involvement, and if the life expectancy is at least more than 1 year, then transcatheter, that is TAVI, is a good option. For those patients where the patients can't tolerate vitamin K antagonist, if the patient is less than 50 years, you can go for a if the patient can tolerate vitamin K antagonist, if the patient is less than 50 years, you can go for a mechanical prosthesis, age between 50 to 65, either mechanical or a bioprosthesis, more than 65, either bioprosthesis in the form of SAVR or TAVR. And for those patients where vitamin K antagonist is not tolerated, for those less than 65, it is bioprosthesis. For between 65 to 80, either SAVR or TAVR bioprosthesis, more than 80, TAVR. Now, what about TAVI, which is a hot topic now? Transcatheter aortic valve implantation. There are two types of transcatheter valve, balloon expandable and self-expandable. These are all bioprosthetic valves. What we do before going for a TAVI, you do a preoperative cardiac CT to look for calcification of the aortic valve, calcification of the ventricular outflow tract, the sinotubular junction, the aortic annulus, the aortic root, the coronary height, the diameter at the various levels. So these are all the criteria that we see before we take a patient for a TAVI. Normally we do TAVI through a transfemoral route, and either it is a balloon expandable valve or a self-expandable valve. So it's already 9:05. I have discussed two topics, and I think to keep it healthy, I think it is better that we stop here today and we take a fresh date, say after 1 week, on a weekday, to discuss the next topic like aortic regurgitation and mitral valve disorders. So is that okay on behalf of the listeners?
Yes, sir. I think
Yes.
so.
Yes. So you can consume easily if you give a gap. Otherwise, it becomes too much for you in 1 day. And I can also have some time to teach you in a calm and quiet manner. So I will request Asif to fix a date next week on Wednesday so that I can discuss the next valvular disorders.
Yeah, it's
Or
a
you can,
nice presentation and nice discussion.
yeah.
So
Any questions from
elaborately,
the students? Is there any question from the listeners?
there is no question in chat box what we are noticing over here.
Okay, I think it was too much for them, maybe. That's why no question.
Basically, it is a large topic and vast subject, na? So
Yeah,
I think
yes.
so. It has been split over the 2 or 3 topics. Today is aortic stenosis. Next day, the aortic regurgitation, mitral, and other valves can be.
That is better, I think. We can also
Basic has
go in
been
a slower
discussed.
pace.
Yeah.
Yes,
That makes
sir.
the
So
thing
Yes, sir.
easy for the speaker as well as for the listener.
So, Sankhoda, we will take another class on mitral regurgitation, and you can put some MCQ type of question meanwhile.
Yes. Next
So,
time I will put some ECGs and chest X-rays,
yeah, thank you.
which will be interactive.
Yes.
That will be better.
So,
I
Sana,
think
you
so.
can conclude.
Yes, sir.
Hmm.
Well, it was a very nice session. Thank you, Dr. Jayanta Sharma and Dr. Shankada Shuprodas. And thank you, Dr. Asif Iqbal, sir.
So thank you all. Special thanks to Dr. Asif and Dr. Sharma for still
Yeah.
being on the topic. I felt they have left. Thank you
No,
so
no,
much.
no. The full topic I have been listened. It was excellent.
So
I
it
learned a
is a
lot
great
of things,
privilege for
specific
me
in
that Dr. Sharma is still there.
the SAVR, the TAVI, and these things. I learned new things actually. This I don't think
Thank you so much.
the recent concepts actually. Thank you,
Yeah.
thank you all of you.
Thank you so much. Thank you.
Okay.
Thank
Thank you,
you,
everyone.
Sankha. Dr. Sharma is always very supportive for the educational program.
Yes,
And
yes,
he
I have
teaches a
always seen
lot
it.
on
He
the
is very
bedside.
supportive. It's
We
very
learn a
true.
lot from him.
So I will request Dr. Sharma to be in my talk, to be in my lectures henceforth, at least to
Sure,
try
sure,
sometimes.
definitely. Because why I am so much interesting because I learn something every day. That is the
Yes,
main reason,
yes,
nothing else.
that is true. We are every day learning from each other.
Yeah, yeah.
Yeah.
Thank you, thank you.
Thank you.
Thank you. We'll see all of you next week.